lecture on traumatic brain injury is a really good time to dip into talking about the recovery of these patients and the long road they may have ahead of them as they are both in the post-acute and recovery stages of their injury. Thank you for joining me for a presentation on neurostorming. Again, my name is Rebecca Conley, and I am a critical care pharmacist practicing in Florida. Let's get started. I will disclose that compensation has been provided for the development of content and the presentation. No funds were provided to endorse any medication or product from the compensating entity. This is a topic to test the diagnostic criteria which aid in distinguishing neurostorming from other disease processes that you commonly see in critically ill patients. We're going to summarize the goals of therapy and patient care because it's very important for safety. And we're also going to review the pharmacology and management of these patients. Neurostorming, though catchy, is not necessarily the formalized terminology for the syndrome of sympathetic storming and autonomic dysfunction we are discussing. In fact, according to literature searches, the syndrome has been called up to 31 different titles over the years, leading to a lack of clear communication about the disease state and likely adding to the delayed recognition and actually treatment of symptoms. The most recognized and fully encompassing name to date is Paroxysmal Sympathetic Hyperactivity, abbreviated as PSH. PSH is highly likely to be missed and underdiagnosed, leading to excessive costs associated with patient workup, treatment, and prolonged hospitalization, as well as overall delayed recovery, which may create chronic symptoms, increasing the patient's morbidity. Some of the names you may have heard this disease state referred to in the past include, but are not limited to, dysautonomia, autonomic storming, central dysregulation, and acute midbrain syndrome. The term neurostorming is used to describe a group of clinical symptoms that occur in patients who have suffered some sort of neurological injury and yet cannot be explained by another disease state. Patients may have any combination of the symptoms listed on the slide, although not all are required to be present at one time for diagnosis. The term storm is used to describe the on and off episodes patients present in, which is actually very key to diagnosis. Patients who are neurostorming may be completely asymptomatic throughout the day with sudden acute presentation of symptoms denoting the onset of an episodic storm. The most common presentation includes agitation, sweating, and an increase in vital signs such as hypertension, tachycardia, increased respiratory rate, and increased temperature. Other more advanced symptoms may include confusion, disorientation, dystonia, and posturing. Dystonia encompasses involuntary muscle contractions that cause noxious, repetitive, or twisting movement disorders. While there are different forms of posturing, neurostorming patients most often present with decerebrate posturing and rigidity, meaning the hands are in an extension position curling upwards and out to form the E-shaped curve, whereas the legs and feet will be extended and slightly turned in towards each other. Decerebrate posturing is common among brainstem injuries. You can visualize these contractures in the image included on this slide. The problem with PSH symptoms is that they overlap with so many other things that could be wrong in a critically ill patient, or a patient who has just left an intensive care unit, or even a patient who has just been discharged from the inpatient setting. Most commonly, these symptoms are confused with sepsis. Just think about a patient coming out of an ICU who suddenly presents with fever, tachycardia, and increased respiratory rate. What is likely to be the first knee-jerk reaction of any provider? Antibiotics. The other symptoms related to mentation mimic ICU delirium, which is very common and often treated with antipsychotics, yet may not be fitting for this pathological process. This is why consideration for history of present illness and recognizing symptoms are synchronized with the time point is so important for differentiation. Diagnosing the patient with PSH can save them from overexposure to noxious medications such as antipsychotics and antibiotics. Antibiotics could lead to adverse drug reactions and future resistant bacterial infections, especially in this population who are much more likely to face future hospitalizations. These patients are usually unable to be consoled and quite uncontrolled during any episode of neurostorming. This can be a very frightening experience for caretakers, family members, and the patients themselves. Prompt recognition, diagnosis, and treatment are key to cessation of storm events and prevention of future episodes. Caring for patients undergoing episodic neurostorming can be very trying and difficult. Demonstrating compassion and kindness is crucial to their care. Try to remember and remind others that these episodes are caused by endogenous catecholamine imbalances, creating a raging stress response in the patient that they themselves cannot control. The reported incidence rates of neurostorming range from 6 to 33% in what are considered to be at-risk patient populations. However, as previously stated, it is hypothesized that these percentages are highly underestimating the incidence due to lack of formal diagnosis of PSH. Conditions that predispose patients to developing sympathetic storming are listed here, with the most common cause being traumatic brain injury. Although no formal consensus, it is believed that over 30% of TBI patients develop PSH following initial insult. This makes up approximately 80% of the neurostorming population. Features of a traumatic brain injury that are associated with the development of PSH were studied in patients who have been followed and reviewed for diagnosis. These associated features include patients suffering from either diffuse axonal brain injury or injury to the brainstem in TBI patients with persistent coma or Glasgow Coma Scale of less than or equal to 8. When thinking about who the majority of PSH patients are, think back to the traumatic brain injury population, usually young male patients and elderly patients suffering from falls. Other neurological insults can also put patients at risk of developing PSH. These include things like brain tumors with an increased tumor burden, hydrocephalus, hypoxia following things such as overdoses, symptomatic hypoglycemia, and cardiac arrest. Patients with strokes and certain head bleeds such as intracerebral and subarachnoid hemorrhages have also been found to develop PSH. Before we discuss the pathophysiology of neurostorming, it is important to review and understand the regulation of body functions by the central nervous system. Made up of two opposing systems, our natural survival responses are controlled by the sympathetic, fight or flight, and the parasympathetic, rest and digest systems. As the naming and presentation allude to, neurostorming is an overproduction of sympathetic outflow, the fight or flight pathway fueled by adrenal releases of endogenous catecholamines such as epinephrine and norepinephrine. Looking at the right side of the diagram, we see the sympathetic system is responsible for things like increased heart rate and increased cardiac output, therefore, bronchial dilation, muscular contraction, pupillary dilation, decreased urine output, decreased GI motility, and increased glycogen conversion. On the opposite side of the diagram, we can see the opposing responses that occur through the activation of the parasympathetic system, or the rest and digest pathway. Many of these responses directly oppose or reset what the sympathetic system does. For example, the stimulation of secretions, peristalsis, and urine, slowing of the heart rate, and bronchoconstriction. Over the years, there have been several different proposed mechanisms surrounding the pathophysiology of paroxysmal sympathetic hyperactivity. With the elimination of seizures as a requirement for diagnosis of PSH and the overall lack of response to treatment with antiepileptics, the proposed theory that symptoms were being triggered by one specific lesion site within the brain was overturned and instead moved to PSH being a result of overall injury burden on the brain. The symptoms are easily described as an outflow of sympathetic stimulation without regulation of the parasympathetic nervous system through a negative or inhibitory feedback loop. The excessive adrenergic outflow increases circulating catecholamines by up to 300% from baseline. In addition, there is a relative reduction in functional dopaminergic activity, creating even more exaggerated responses to benign stimuli. When looking at how this actually happens, two hypotheses have been proposed to date. First is the disconnection theory. This theory proposes that due to direct cellular injury, perhaps something like traumatic brain injury or anoxia, pathways of communication between the functional brain and the spinal centers are no longer intact. This results in failure of normal autonomic regulation, and the disconnection is thought to occur somewhere between the higher centers of the brain, such as the upper brainstem, cortex, throughout the hypothalamus, and the cortical centers, from the lower brainstem and spinal cord that control responses to stimuli by opposing sympathetic outflow. Loss of inhibition due to the inability of inhibitory messengers to travel upward to the higher functioning brain tissue results in the PSH. The second mechanism of PSH is related to the imbalanced excitatory to inhibitory ratio of neurotransmitters. Due to the imbalance and excess of excitatory messengers, paroxysms are the result of abnormal processing of afferent stimuli, which is normally regulated by the spinal centers. The E to I ratio imbalance theory applies to many of the overlapping syndromes of autonomic overactivity, including autonomic dysreflexia, malignant catatonia, and malignant hyperthermia, for example. Central sensation processing is upregulated and overpowers the inhibitory response centers, increasing sensitivity and allowing for exaggerated responses to minor or even normal stimuli. Due to lack of formalized research devoted to PSH, much of the information is from case reports and small observational studies. From what has been reported, it is thought that the timing of onset for neurostorming may actually be very early following initial injury. However, due to use of continuous analgesia and sedation while in the intensive care unit and requiring the use of mechanical ventilation, suppression of key features is highly likely. Symptoms of PSH are more likely to present following discontinuation of continuous analgesia and sedation therapy or following cessation of induced hypothermia through target temperature management. Again, this raises the risk of confusing the syndrome with abrupt discontinuation or withdrawal from opioid and benzodiazepine therapy, which could be another differential diagnosis. The onset of episodes may be directly following or weeks after initial injury. Episodes are likely to occur multiple times per day with almost complete resolution of symptoms between exacerbation periods. Episodes may last anywhere from 30 minutes to 2 hours depending on the effectiveness of treatment for cessation. Patients may suffer with storming for only hours, but many are faced with the burden for weeks to months following injury, and some residual symptoms have lasted up to 5 years in case reports. For years, the diagnosis of paroxysmal sympathetic hyperactivity relied solely on the exclusion of other disease states such as infection, malignant hyperthermia, malignant neuroleptic syndrome, serotonin syndrome, and endocrine disorders such as thyroid storm. This is largely due to the complicated crosswalk of PSH symptoms to disease states we are commonly searching for in the moments of making a differential diagnosis. In addition to sepsis, ICU delirium, and withdrawal, which we have already discussed, other pathological processes such as pain, new onset distal venous thromboembolism or pulmonary embolism, severe dehydration, seizures, and various other intracranial insults all share common presentation features with PSH. Using information from the patient's past medical history, history of present illness, and current laboratory findings can help rule out many of the differentials. Failure to diagnose PSH correctly leads to failure to treat PSH correctly, potentially creating more harm for the patient. For example, while the standard treatment for malignant catatonia is actually ECT or electroconvulsive therapy, this same treatment can provoke exacerbations of neurostorming. In 2014, the Consensus Working Group for Neurological Injury developed a conceptual definition, formalized nomenclature, and diagnostic criteria for paroxysmal sympathetic hyperactivity. They recommended the use of the PSH-AM, which is seen here and consists of both the clinical feature scale and the diagnostic likelihood tool, also known as the CFS and the DLT. Their interpretation of results comes from adding up both scores received in the two. The clinical feature scale assigns a score of 1 to 18 based on the symptoms that occur during a neurostorm episode. It looks at the clinical findings, like heart rate, respiratory rate, blood pressure, temperature, sweating, and the presence of posturing. That score is used to categorize how severe the storming episode is. Scores of 1 to 6 are considered mild, 7 to 12 are considered moderate, and any score greater than 13 are considered to be severe. The Diagnostic Likelihood Tool, or DLT, assigns a score of 0 to 11 based on the assessment of features that help distinguish PSH from other differential processes by examining the episode itself. The DLT assigns 1 point for each criteria met and heavily relies on the timing of episodes in terms of onset from time of injury, how many days the episodes are occurring, and how many times per day the patient is being affected, in addition to other clinical features such as treatment response and the lack of parasympathetic findings during the episode. Again, the two scores are added together to determine if PSH is likely, possible, or probable, which requires a score greater than 17. Although quite cumbersome to use, this is the best way to truly diagnose a patient with PSH to date. The goals of therapy for a PSH patient are pretty straightforward. Number one should always be to protect the patient and the staff, honestly, and that's by using things like chemical restraints before mechanical constraints, using your bed rails and bed alarms, using the buddy system so that when a nurse is off the floor, somebody is still watching the patient, and controlling symptom triggers, so these episodes may be set off by things like loud noises and bright lights. Although these items seem to be a little bit out of the wheelhouse of pharmacy, it's really important you keep them in mind and you bring them up when talking about these patients on rounds. The next goal is to treat the symptoms and manage the storms. Things to consider are things like temperature management, reducing inflammatory markers, allowing for maximized cerebral blood flow, controlling heart rate, and reducing blood pressure. Many studies reported efficacy of drugs for PSH in clinical practice. In most of these studies, multi-drug therapies are generally recommended and required. Using pharmacological therapy for the treatment of neurostorming targets inhibition of afferent sensory nerve impulses, downregulation of central sympathetic outflow, and reduced in-organ response to the sympathetic nervous system. Another goal of therapy for PSH patients include mitigation of the associated adverse outcomes. Adverse outcomes can arise due to the medications we have to use or to the disease state process itself. Adverse outcomes to monitor for and help mitigate include contractures, dehydration, delayed recovery, muscle wasting, and organ dysfunction. The presence of proximal sympathetic hyperactivity, especially without recognition and appropriate therapy, potentially increases the rate of patient mortality, morbidity, the cost of care, and length of stay. Without treatment, the persistence of PSH increases the risk of adverse outcomes, such as cardiac overload, arrhythmias, dehydration, muscle loss, and contractures, which all worsen the patient's prognosis overall. Episodic presentation of things like hyperthermia, increased catabolism, the increased stress response due to endogenous catecholamine overload, in addition to the spasticity and dystonia, are all detrimental to the patient's health and recovery process. Secondary injury may occur from any of the above and result in cardiac arrest, cerebral hemorrhage, organ dysfunction, and rhabdomyolysis. The management of proximal sympathetic hyperactivity is primarily pharmacologically based, with the most common drugs used being those that depress primarily the sympathetic component of the central nervous system. Treatment selection may vary based on provider experience and can require many trial and error periods based on the patient's response. Providers may choose therapies based on either the prospective pathology of proximal sympathetic hyperactivity or by making a selection of drugs according to the patient's specific symptoms. The overall goal of medication is to reduce the sympathetic outflow or to mimic the parasympathetic system in terms of regulation. Sedatives, opioid receptor agonists, beta blockers, and CNS depressants are the mainstay of most protocols for PSH management. However, due to the need for frequent neurological assessments in what may already be a minimally responsive subject, use of agents that interfere with the responsiveness are ideally avoided or used at best only minimally. Perhaps the most beneficial approach to management of PSH includes the employment of a sympathetic blockade while reserving the more extreme agents such as fentanyl, midazolam, and even propofol for refractory cases. Opioid therapy such as morphine has been successfully used to help control most of the refractory symptoms possible through not only decreasing the natural fight or flight response provoked by pain and therefore blunting the sympathetic activity, but potentially also in relation to a direct effect on the opioid receptors in areas of the brain such as the hypothalamus, which actually decreases blood pressure and heart rate. Sedatives such as lorazepam have also been used as a cornerstone of PSH management, but again may greatly affect the neurological assessment of patients. Benzodiazepine therapy has been shown to reduce both respiratory rate and hypertension in case reports of PSH. Making use of multimodal therapy is likely to provide the most benefit while reducing the risk of patient harm and adverse drug reactions. Drug therapy can be selected based on complementary mechanisms and effect, which can be tailored then specific to a patient's needs. Making use of moderate doses of several agents in comparison to using extremely high doses of singular drugs reduces the risk of undesired side effects and potential toxicity. Selection of medication may also differ based on the desired goal of either abortive or preventative therapy. Although medication classes are not exclusive to being either solely used for abortive versus preventative therapy, there are certain features of medication to consider when prescribing an abortive therapy for acute use and a therapy regimen for prevention and management of symptoms long term. Abortive agents need to have the ability to be readily available, they are able to be given intravenously, and also have a rapid onset of activity, such as a bolus push dose of midazolam or morphine. Preventative medications used for PSH should also be tolerable long term without the risk of tolerance or withdrawal, be available as oral preparations, and also be accessible for patients in the outpatient setting. In the next slides, I will discuss agents used in PSH to create a sympathetic blockade. These agents can be used in combination with each other, mainly as preventative therapy options to free the patient from medication regimens made up of primarily opioid agonists and benzodiazepine therapy, which are associated with adverse outcomes in many populations when used long term. Propranolol is a non-selective beta blocker, which expectedly decreases both blood pressure, and heart rate, and has been independently associated with decreased patient mortality when used in sympathetic storm-type situations following neuronal injury. In addition to reducing the cardiac workload, the blockade at both alpha and beta receptors, as well as reducing the level of circulating serum endogenous catecholamines, results in decreased sympathetic activity, and therefore slowed neuronal response time. Due to the drug's lipophilicity, propranolol is able to be freely penetrated through the blood-brain barrier and therefore reduces central fevers by acting directly within the central nervous system. Non-selective beta blockers also reduce the metabolic rate, which is often elevated and may help with reduced dystonia. The dose of propranolol is titrated up gradually to control and prevent episodes of neurostorming. Starting doses may range from 20 to 60 milligrams every 4 to 6 hours, much like the doses used in thyroid storm. The doses can be titrated up to a total of 640 milligrams per day. Monitoring should include heart rate and blood pressure, although both seem to be largely unaffected in younger TBI patients, warranting increased doses. Other side effects may include somnolence and masked hypoglycemia. Use of beta blocker therapy should be avoided in hypotension, bradycardia, and patients with heart block. While betalol may be an effective alternative agent to propranolol, but there is limited data on the other non-selective beta blockers at this time. Unfortunately, metoprolol and the other cardioselective beta blockers are thought to be somewhat less effective as they are missing the alpha-adrenergic effect that may be required to control the patients. The class of alpha-2 adrenergic antagonists are particularly useful in PSH due to the direct central activity in both the brain and spinal cord, resulting in downregulated sympathetic activity. These agents are most useful when patients have some degree of tachycardia and hypertension even between neurostorming episodes. Each of the alpha agonists have sedative properties which may be helpful in PSH patients, although oversedation should always be avoided. Clonidine and guanfacine's activity in the prefrontal cortex of the brain, which is responsible for the interpretation of stimuli and behavioral response, creates a robust downregulation of the sympathetic nervous system. Guanfacine is also known to enhance noradrenergic activity in the same area of the brain, which allows for greater impulse control, increased working memory, and the ability to focus attention, which is why the drug is commonly used in attention deficit disorder. Dexmedetomidine is recommended for patients found in the inpatient setting due to only being available as an intravenous formulation. A benefit of using dexmedetomidine is that it can be titrated up during episodes and to either lower doses or completely stop between events, allowing for less overall drug exposure and less effect on heart rate and blood pressure in the long run. Bolus dosing of dexmedetomidine should be avoided due to unpredictable effects on hemodynamics. For patients who are well controlled on dexmedetomidine, an oral regimen of clonidine can be used when transitioning to the outpatient setting. Use of clonidine and guanfacine, especially in the extended release forms, as compared to dexmedetomidine, may be limited in patients with PSH, since the long-acting agents may potentiate hypotension and bradycardia between episodes, making titration very challenging. For patients on stable clonidine regimens, patches may be an effective alternative to consider in the long term. Dosing of all agents should be started low and titrated based on tolerability. For clonidine, a maximum daily dose of 1.2 milligrams has been suggested. Guanfacine dosing ranges from 0.5 milligrams to 5 milligrams dosed once daily, and dexmedetomidine dosing for PSH follows normal dosing suggested for ICU sedation, ranging from 0.2 micrograms per kg per hour to 1.5 micrograms per kg per hour. Gabapentin is a gamma-aminobutyric acid, also known as GABA agonist, that acts specifically at the alpha-2 delta presynaptic voltage-gated calcium channels in the brain and the spinal cord. This specific activity is much different from benzodiazepines in that gabapentin does not actually act at the GABA receptors or influence circulating GABA concentrations. Binding at the voltage-gated calcium channels in the brain and spinal cord helps to recover the inhibitory control of the descending and afferent feedback centers, which is necessary to mitigate unregulated sympathetic outflow. Certain binding properties of gabapentin have also been shown to modulate the release of excitatory neurotransmitters, which are related to leptogenesis and nociception. Another contribution of gabapentin is through the modulation of allodynia and treating neuropathic pain, as well as reducing spasticity. When using gabapentin for paroxysmal sympathetic hyperactivity, it can also serve as part of a multimodal pain approach. Remember, pain acts as an activator of sympathetic stimulation, which in turn can result in triggering of PSH episodes. Dosing starts at approximately 300 milligrams q8 hours and can be quickly titrated every 2 to 3 days as necessary to a daily maximum dose of 4,800 milligrams. Gabapentin is well tolerated for long-term use by most patients. The side effect profile make it a great option for patients suffering from hypotension or bradycardia at baseline, since gabapentin has no effect on hemodynamics. It can also be added on to agents that do impact blood pressure and heart rate without risk of compounding those side effects. Patients should be monitored for ataxia, peripheral edema, and hyperglycemia while taking gabapentin. Baclofen acts as a GABA agonist at inhibitory neurons in both the brain and spinal cord. Much like gabapentin, it also binds to presynaptic voltage-gated calcium channels, providing central and peripheral control of sympathetic release and response. Baclofen is most advantageous for reducing pain and movement disorders in patients suffering from PSH, such as spasticity, dystonia, rigidity, and clonus. Baclofen dosing for PSH starts at 5 mg every 8 hours and can be titrated up to a daily dose of 80 mg. It should be noted that oral baclofen may not control symptoms of spasticity in patients with spinal cord injuries. Intrathecal or intraventricular baclofen has a key role for patients with spinal cord injuries or those with persistent dysautonomia or posturing despite other therapies. The side effect profile includes sedation, hypotension, and the potential for withdrawal. Patients with intrathecal or intraventricular baclofen pump failure can lead to abrupt severe withdrawal or potentially fatal overdoses. Bromocriptine is a dopamine receptor agonist effective in reduction of hyperthermia and diaphoresis. Recommended starting doses are 2.5 to 5 mg given orally 2 to 3 times per day. Some providers may choose to use weight-based dosing as an alternative option, especially when being used in pediatric patients. Doses may be increased to a maximum of 40 mg per day in adults. Secondary activity of bromocriptine may include modest decreases in blood pressure, dystonia, and posturing, also related to paroxysmal sympathetic hyperactivity. Side effects such as agitation, dyskinesia, and confusion may add to the patient's current clinical deterioration, and side effects such as seizures and nausea may cloud the picture when trying to rule out other etiologies. Dantrolene acts directly on skeletal muscle tissues by inhibiting the release of calcium from the sarcoplasmic reticulum and therefore prevents or reduces calcium ion concentrations responsible for acute catabolic increases in temperatures, such as the pathology seen in malignant hyperthermia. Due to direct effects on calcium release, muscle contraction is also inhibited, aiding in the reduction of posturing, spasms, and the rigidity seen in paroxysmal sympathetic hyperactivity. Side effects of dantrolene are common, and the agent should be titrated with great caution. Starting doses of 25 mg daily and titration to a weekly maximum dose of 400 mg is achieved over time. This agent is beneficial in that it can be used both orally and intravenously, as doses of 1 to 2.5 mg per kg initially, then 1 mg per kg up to every 6 hours as needed to control symptom presentation. Monitor patients receiving dantrolene for anemia, heart blocks, hepatotoxicity, respiratory depression, and tachycardia. Aside from medication interventions, there are other things that can be done that are useful for PSH management. For one, providing an environment that is free of episodic triggers. Using low volumes, dim lights, and a cool room temperature, along with prevention of pain or excitement, are all really helpful. It is also very important to stay on top of recognition of symptoms by closely monitoring for change in neurostatus, changes in electrolyte concentrations, and watching the vital signs. Early recognition can lead to early administrations of medications to stop the storm. Other interventions to consider for these patients are advanced and increased nutrition support. PSH patients can have energy requirements 2 to 3 times their baseline due to increased catabolism. Staying on top of hydration and making use of ice packs or cooling blankets during times of hyperthermia is also likely to be required. Thank you all for joining me for this presentation.